Hiya Joe, hiya Nikki. So we're
Hi.
just here today, just to have a little bit of a chat and just really introduce ourselves. So it's really about how we're going to link education and health together, really to give our students in both nursing, midwifery and allied health professionals a little bit of an idea how we can link that. So I'll just ask yourselves just to give you a little introduction around what your roles and responsibilities are and a little bit of experience that you've got.
My name's Jo Blackham. I'm the head here at Mount Pleasant School. I've been here for about 12 years and I'm currently the DSL, so busy with that quite a lot.
And my name's Nikki Lupton. I'm the Deputy Provision Leader at Mount Pleasant. My role is also the SCOS advisor for Darlington as well, which means I go into other schools advising on how to deal with autism and ADHD and things like that. I've worked with autistic children for 30 years and I've been at Mount Pleasant for 20 years.
Brilliant. Joe, just dipping back into your introduction, DSL, would you just be able to elaborate on what DSL actually is, just for us health professionals not too sure?
Yeah, so the DSL is the Designated Safeguarding Lead. So I am ultimately responsible for every for all safety across the whole of school. So that encompasses everything really. It's child protection, health and safety. It's everything that it pertains to keeping children safe in school.
Brilliant, thank you. So we're just going to have a little bit of a chat just really around how health and education link. Now, I'm very much aware that some of our students that have previously worked in acute settings or community settings are not quite sure how health is incorporated into school health needs. So Joe, would you just be able to tell us when a child actually comes to the school, how is it identified, their health needs? How is it documented? Do you have a care plan? How is that actually started from the beginning of that child entering the school?
Yeah, so right from a child registering for the school, we have an initial meeting, and in that meeting with we have a homeschool mentor in school. She meets with the parent and discusses any issues around the child, whether they've been previously on child protection or whether they've got any specific health needs currently. We have all kinds currently in school. We've got about 34 children who have a care plan in place. So what that entails is that the homeschool mentor and the parent together discuss the health needs of the child, and then we put a care plan which identifies. Would you like me to show you a care plan?
If you don't mind showing us what your care plan looks like, and then we can have a little bit of an idea as to the type of questions that are asked.
Okay, can you see the care plan now?
Yeah, the care plan's up.
Okay, so
it was up, it's gone now.
Oh, it's gone.
Up.
Okay, let me bring it on that screen.
Yes,
okay,
it's up now,
so as you can see, if we go down the care plan, it has general information about the child. It has the general condition, what the medical condition might be, what triggers might be, signs and symptoms, so that we can share that with any staff involved with the child, so that they are absolutely clear on what that child needs may be. And then it literally just goes down through the care plan, everything that might be needed as far as medication, who might be administering the medication, when it might be needed, what staff might need to do given any if any medical, if any things occur. That's then signed with the homeschool mentor and the parent, and then that's shared with staff, any staff that are involved with the child. I mean, that might include people like kitchen staff. So if we've got a child that say has a milk allergy or a nut allergy, it's really important that the kitchen staff are aware. So the kitchen, we go so far as to have a register in the kitchen with a photograph of the child to say exactly what it is that child can't have, and then specific menus are put in place. So it really is a very comprehensive plan right across schools, so that we make sure that we keep our children safe. So that's on the kind of the very basic level of a care plan. We have children who have food allergies. We've got a child who's got really severe eczema at the moment. We've got many children who've got asthma, for which we have an asthma register and then guidance within each classroom. We've got a number of urinary not infections as such, but what's the word? Yeah, conditions. So yeah, so we've got, so staff are kind of quite aware now. We do a basic first aid, but they also are really quite knowledgeable about many different conditions in school, for which, and we also have specialist nurses who come in, so they'll come in and do asthma training, they'll do EpiPen training. So as a staff, we're really quite knowledgeable about lots of different medical needs.
Yeah, and I'm assuming also with some cases you'll link it with consultants around any extra support that staff may need.
Yeah, so that would then go on to, we have some children then who have an education healthcare plan. Currently, we've got, by the end of this year, we'll have 35, which in our school, which in any mainstream school is really quite unique. You generally don't find a mainstream school that has so many EHCPs because of the nature of the children. Generally, it's quite a highly specialised plan. Nikki will talk a little bit about that in a minute, but so our EHCP plans can be around a child who has a cognitive learning disability. It might be a physical disability, it might be an ASD, social communication, but that plan is a really comprehensive plan that does take the views of specialist consultants and people like that.
Brilliant. I'll ask you to stop sharing your screen just so we able to see each other a bit better. In regards to medications management, is there a policy that you've got in regards to medications management? You know, obviously in a hospital setting, certain medications would need double, signed for. Some would need a counter signature. Does that happen with yourself? How does the medications work with yourself?
Yeah. So we've got a administration of medicines policy. Again, agreed with the parents. We only would administer medicine if it's something that needs administering through the day. So if it was something like an antibiotic that was only 3 times a day, the parent would be expected to do that. There would be no need for school to do that. But in some cases, if you're using things like Movicol or an ADHD medication, for example, that needs administering at lunchtime, then we have trained people who do administer it. They have to have the qualification to do that. So we have 3 people trained in the administration of medication. That's agreed with parents. It's all the paperwork signed off. And then when the child does have the medication, it has to be agreed with 2 members of staff to make sure that the child is getting the right medication, the right amount, so that, again, right back to safety. Nothing goes doubly monitored.
Yeah. And just bring yourself in, Nikki. So we touched on education healthcare plan. Would you be able to tell us a little bit about what an education healthcare plan is? Where do we start with an education healthcare plan as health professionals? We focus very much on health needs of children, but obviously with the education healthcare plan, that's a little bit different. It does have health involved, but if I just let you expand a little bit on that.
Yeah, it's usually the school and parents that discuss the possibility of an education healthcare plan, but that plan will be done by the SENCO in the school, but working with parents and working with staff. Then they need to have educational psychologists involved, maybe occupational therapists, and there's a whole load of professionals that are involved in that. The plan will go to the local authority, and they look at it and they decide whether that child qualifies for the plan. This is because it's a legal document, and it also comes with money for the school as well. It's not a lot of money. It doesn't cover, because most of the children will need extra support. So it would be a teaching assistant, but that money doesn't cover for a teaching assistant. So school has to pick up that extra money for that support. So we do work very closely with parents. The plan looks at parents' views and what they expect from their child. It looks at the child's views, what the child wants or would like in the future, if they're able to verbalise that, because obviously some children are non-verbal or are not able to do so. And then all things put together, and then the child will have some outcomes. So we need to look at the outcomes as professionals and work on those. So it brings in, although we've got to work on the educational side of things, we've also got to work on their health needs as well. So it's a lot different to how it was years ago. Sometimes the health needs are more prevalent to the educational needs. So we've got to do a lot of, you know, we might need to do some physio, we might need to make sure that the child has movement breaks if they have ADHD. There's a lot of things we need to do alongside the education side of things as well.
And when we look at obviously health professionals, we're talking about, you know, how sometimes health can be a little bit more dominant with the EHCP than the social and the education side of things. And I think it's being aware, you know, as a health professional, being aware of that child's condition and how that can impact. And I know myself and Jo have spoke in the past about, you know, children may have a phobia around somebody wearing green, you know, so if that paramedic came in, how that could escalate their behaviour. It's obviously sometimes overtakes the condition that they've actually come in to see about. So it's really just about elaborating on that, with that being your speciality, Nikki, just really looking at how we can, you know, in that gold standard life that we'd like to live in with children, obviously within schools, how health professionals can look at coming in and dealing with them, what experience we could possibly, you know, look at getting more of.
Yeah, I think if a health professional is coming into school, I think the most important thing is that they speak to a member of staff that knows the child that they're coming to see. Because we as staff know our children inside and out. We've got to know everything about them. And having that relationship with that member of staff is definitely is a need, is a must. Because there's a lot of issues around unfamiliar staff, unfamiliar people coming into an autistic child's you know, into their environment, can be quite challenging for them. So it has been but also being aware of their sensitivities as well, because they could be sensitive to touch, to smells, to fabrics, to noise. So if a paramedic, for example, is coming in with a noisy bag and, you know, a helmet on, or, you know, or whatever, you know, they've got to be aware of these things might upset the child. I've got a pupil that I work with who doesn't like hats and things. So she would freak out if somebody walked in with a helmet on or a hat on or something like that. So it's being aware of that child and the issues that they may have. Smells as well is a massive thing. So if they're coming with chemicals, even perfumes and things like that, we've got to be careful about how much perfume we wear and things like that, because it can be overwhelming and overstimulating for them. The child that they're coming to see might be non-verbal or very limited language, and that obviously can be quite tricky. They might not be able to show their feelings or their emotion, might not be able to show their pain. So you could have a child that's in severe pain but not showing any body language, not showing any signs that they are in pain. It's just being aware of giving eye contact as well. Eye contact can be physically painful for an autistic child. So it's just being aware when that person is dealing with the child to not constantly stare at them. I'm not saying anybody would, but it's not natural to do that anyway, but it's just being aware of that eye contact and just making sure that they're turning away when they're talking to them as well.
And I think that's really interesting, because I think in our profession as health professionals, it's always about that communication, our body language, and making sure that we communicate with that patient. But you've pointed out something, you know, really valuable there, I think, for our health professionals is that eye contact, because, you know, we often do make sure that we give that eye contact. But for somebody who with autism, you know, it can be quite daunting, can't it?
Yes.
Now, Jo, I know that you've got a couple of case studies. If you want to bring the case studies up, just so that we can possibly work through and have a little look through some of the case studies, just to give our students a little bit of an idea as to what we're going to be talking about.
You see that?
Yes, we can. Yes, we can. So we have got case study 1 is around Bobby, who is age 6. Bobby is a very active child. He has ADHD diagnosis and finds it very difficult to be still. Bobby has very limited language and understanding of language. Although staff try and stop him, he will climb and jump off high tables, cupboards, etc. in order to seek sensory input. Bobby has jumped off a table and has landed on his arm. He isn't crying or screaming in pain, but he has been moving his arm. He isn't moving his arm at all. How would you approach this? Can I put that back over to yourselves, just to give us a bit of an idea as health professionals, how you would like us to come into your school and approach this, knowing obviously the experience that you've got around children with ADHD?
Mm-hmm. So first of all, like I said, the health professional would need to speak to a member of staff that knows the child first. That's vital, just so that they can give a quick sort of overview of the child and what is the child's needs. But for this particular child, you shouldn't ever, like I said before, assume that the child isn't in pain because they're not crying or showing any body language. Obviously, ask the adult who is familiar to the child. You may need to talk to the adult instead of the child. So if they're working on the child, they may need to talk through the adult so that the adult can simplify the language and use language that the child would understand. A weighted blanket for this particular child, a weighted blanket might help, because with ADHD, obviously they do find it difficult to sit still and they might want to move around. And if he has broken his arm, for example, we would want him to be moving around. So it would be good if they could ask for a weighted blanket to put on his body, just to try and keep him still while they're working on him. So it's just about approaching him with caution and not just going rushing straight at him and getting too close to him. That would be something that, you know, would probably frighten them, especially this particular child.
Is that something that would be available in school generally, Nikki? Do they have things like weighted blankets?
Yes.
They do.
Yes, but this should, I can't speak for all schools, no, unfortunately, but a lot of children with ADHD like to have a weighted blanket. So, you know, if not, it just any sort of pressure, just if somebody, I don't want to mean anybody to sort of lie on them or anything, but just to sort of give them some pressure of some kind, just to, for a familiar adult, just to hold them, just so that they can feel where they are, because sometimes children with ADHD don't know where they are. They feel like their arms and legs are flying off their bodies and things. So it's just to give them that sense of a sensory input and sensory stability.
Security, yeah. So that's obviously looking at case study 1. We'll look at case study 2. So Sophie has ASD diagnosis. She is very timid and sensitive to touch and noise. Unfamiliar people can cause anxiety and will sometimes have a meltdown if approached. She has an understanding of language. She has an understanding of language, but will only engage with familiar adults. Sophie's fallen outside and bumped her head. She is bleeding from an inch-sized laceration. How would you approach this, Nikki?
Yeah. So again, I mean, the key words there, you know, she will only engage in familiar adults. She does find it difficult to speak to or be around unfamiliar adults. So again, it's about not giving too much eye contact. She's very sensitive to noise. So if for example, we're outside, it's just, I don't know where it's possible to turn sirens off or anything like that. And it's just about not trying to make too much noise and too much fuss around, like I say, rattling of equipment and things like that. It's about trying to keep it as quiet as possible. I know that would be probably difficult sometimes. if there's anybody crowding around, you would need to ask them to move. There shouldn't be anybody standing around them because crowds can be intimidating. Obviously, again, make sure the adult is familiar to the child, the adult that is with the child. Talk through the adult so that the adult can then talk to the child again. And just use a quiet, calming voice, which can be key as well, because I mean, I know everybody's got a different kind of voice, but if it's you know, somebody with a loud booming voice, that could be quite intimidating as well, and that child might not want to be you know, might not want that adult to sort of help them.
Yeah. And I think, you know, what I'm getting from this, what you're saying, Nikki, is very, very similar. And I think that's very much around, rather than come in and treat the health issue initially, we need to look at that holistic, that bigger picture, don't we, around that condition. So it's about that clear communication, I think, with that adult, but it's also around, you know, we're not going to get anywhere with anybody's health needs, whether it's a broken leg, a broken arm, or any laceration, until we've actually calmed and de-escalated that situation with a child.
Yes, that's right. That's important.
And we know that all of our staff across school are very aware of that, because it's not just, that's the same, not just with autistic children, but with our neurotypical children as well. If you've got a lot of noise and everyone's frantically running around, or you've got a crowd, you know, that heightens their sensitivity, and then it makes them more frightened. So as a staff, we're all very aware that you need to back right off and just have the key adults around who know what they're doing, so that the child stays much calmer than they would do if there was a lot of people around.
And I think if we were to possibly move this from a school setting into a, say, children's ward, you know, with the experience that you've got with children de-escalating different types of situations, heightened, and it's not always an injury, it can sometimes just be an incident that that child's actually doing in a classroom setting. So if we were to relate that and take it into onto a children's ward, and we would kind of think, seeing that child responding, jumping, acting like that, how or what would you say would be the best technique to use? I know every child's different, but what would you say would be the very basic technique to use with anything to de-escalate situations that are really heightened?
Well, it's really difficult because it depends on their it depends on their needs. But I would again, just talking about what I've said there about the limited eye contact, about the noise levels, and about just making sure, I mean, it's always good to make sure those things are in place anyway, regardless of the need of the child.
Talking to parents would be a good idea to see what they would suggest. But with some of our children, what we find is really good is that we use a technique called planned ignore. So if you've got a child that's not doing the right thing, or is up, you know, up a height and stressed, what we do is two adults, we would start having a conversation about something that the child might be interested in. So it might be football, not that I know much about football, but it might be football, or it might be superheroes, and they very quickly start to listen to what the adults are saying, and then become interested in what the adults are saying, and in that way then they start to calm down, and then they want to then be engaged in a conversation. And that's kind of a very basic behaviour technique that we tend to use with some of our children who are you know, feeling quite stressed. Again, they're probably not the ASD children. They might be just other children who were over excited about something. But that's a really good technique, isn't it?
Yes, it is.
Just a planned ignore of, we're not going to listen to you, we're going to talk about what we're going to talk about, and then they then get sucked in. You see, it's quite a clever little trick.
Yeah. Definitely, that sounds like a really good plan. So if we were to talk about different, obviously, health needs in school and how we link these to the education and social care, could you possibly give us a little bit of an idea around social education and health and how we link together? I know we've talked about education, healthcare plans, Is there any other way that we link in? So possibly, you know, if you've got a child with an SEND need, how do we link that child with an SEND? How is their care linked as such?
Oh, it can be, well, it can be lots of different ways, really. So I'm thinking of some of our SEND children we've got who might have mental health, you know, they might have some mental health needs. So we would engage counsellors in that. It might be that you might have a special needs cognitive and learning, but they might also have medical. Honestly, you can have so many different combinations of children that within their plan, you've got literally 5 different professionals. I mean, we've got one little boy at the moment who is in a wheelchair, and he has a full-time care, and he's got a condition that we can't even pronounce. But he's aside from his medical condition, he then has additional support from lots of other agencies. So
regular MDT meetings, I suppose, Jo, is that what you're saying?
Yeah,
it's that
yeah.
regular connection with MDTs.
Yeah. So yeah, and we do. I mean, as we're not just teachers anymore in school, you know, teachers or teaching assistants. We literally kind of thread into lots of different areas now, and health is so important because we can't teach children. Children are not ready to learn until you've met all of those underlying needs. And so we have to provide all of that support in school before they're even ready to walk into a classroom and sit and learn. So that's, you know, that's where health is so important in school.
And we're also expected to prepare them for adulthood as well. Yeah. So this is a big thing at the moment as well. We've got to make sure that these children are prepared for adulthood. So that brings in, you know, the social side of things. You know, we've got to have them ready. We've got to be able to teach them how to walk down the street. We've got to be able to teach them how to go to a shop and buy something. That's down to us to try and do that with the children as well as educate them.
And I think that's how you're linking your health, your education, your social care together, isn't it? It's very much about that preparation of that longer term plan of their life, really. So if we were to look at bringing health students into school, which we do, Jo, what would you say would be the biggest benefit, and what does a day as a health student look like in a school, and what are the benefits?
Well, we've over the last couple of years we've done an amazing project, haven't we, Emma? Where we've had dietitian students, we've had physio students, nursing students, and they've come in and worked alongside our staff to they've put workshops on actually with across school. So as students, they've been brilliant. They've worked alongside teachers, they've prepared materials, and then they've gone into classes and taught children about their speciality. So that's been great. That then feeds into our PSHE curriculum, because PSHE is massive in this school. It's probably one of the biggest areas of the curriculum. So they've been able to support with their expertise in that. And then just that kind of general relationship, signposting, talking, giving advice, that's been the biggest benefit of our students coming in. Things like we had dentistry students in last year, and that was great because in the EYFS curriculum, it was a new part of the EYFS curriculum that teachers were expected to teach about dental health because of the massive need there is at the moment. So dentistry students came in and worked again with classes, with teachers, and gave some expert advice, so that was then part of the EYFS curriculum. So it's been really, really beneficial and an excellent partnership.
And I think for the health professionals that are coming into school as well, it's giving them an understanding of the needs that we have in school. So, you know, an understanding of the autistic children, the ADHD children, all those children with those kinds of needs. It gives them an insight to what we deal with on a daily basis, because it's not easy sometimes. And I think some people do get quite a shock as to, you know, how we have to deal with their need, as well as educate them, as well as taking care of them. It's just an eye opener, I think, for those students coming in to see.
I think as well, it's a setting where, as health professionals with children and young people especially, we only really get to see them with parents, so we kind of don't get to see them by themselves talking freely, you know, that type of thing. So I think school is that big benefit as well, whereby we can actually talk to children at their level, you know, responding to their needs really that they require, rather than always the parent there as well. Oh, well, that's really, really good. That's been very, very beneficial. And hopefully, you know, our students will benefit from this conversation in future, and be able to support children with SEND needs, look at, you know, that bigger picture when they do come into, you know, establishments like yourself, or even onto the ward, or even in a home environment. It's just that, I think, being mindful really of, before we respond, actually think of what we want that outcome to be, because we can really escalate it quite quickly if we don't, you know, put the proper measures in place.
Yeah.
Yes.
Thank
Brilliant,
you.
lovely. Thank you.
Thank you. Bye.